Hi everyone, my name is Anna. I will cover on asthma between the pathophysiology of the acute exacerbation of the disease and its clinical manifestation, especially dyspnea. Basically, this presentation will be divided into 4 parts: background, 2 types of asthma, pathophysiology, and the clinical manifestation, and the intervention. Case study of Mr. Jackson will be drawn on this presentation. Before starting my oral presentation, would I ask one question from your guys? Does anyone know that 1 out of every 9 Australians suffers from asthma? Let me tell you that as many as 2.7 million Australians suffer from asthma, which accounts for 11.2% of the total population. Furthermore, asthma has caused 436 deaths in Australia in 2019. Nevertheless, nearly half of all asthma hospitalization occur in children under 14 years of age. Alright, let me have a look at this picture. Normal lung with a clear airway, which comparing to the asthma's airway with 6 markers. Obviously, it is hard for air to pass through the narrow airway. Since most people with asthma are easily develop frequent coughing or short of breath. Here is the picture. People with asthma may have following symptoms such as chest pain and wheezing and so on. During this time, I just wondering most people probably will think why asthma gonna happen in the people's lifetime. What is the reason behind this one? Is anyone having any clue about it? That's okay. Please let me explain to you guys. Asthma is made up of 2 parts, which is atopic and non-atopic. Regarding to the atopic, people may allergy to pollen, pet, and dust mite. However, non-atopic asthma is thought to be airway inflammation, which lead to hyperresponsiveness of bronchioles and the remodeling of the airway secondary to repeated episodes of inflammation. That situation presented at the previous slides. In this respect, I would elaborate on the pathophysiology of asthma, such as several dyspnea, and the effective nursing intervention which would help to provide relief to the patient based on the evolution of the case of Jackson Smith, an 18-year-old male having asthma for 2 years of age. For the pathophysiology, when Jackson inhales an allergen via his airway, T helper 2 cells release immunoglobulin E, which leads to the surface of mast cells and cause them to degranulate. The cells release histamine and prostaglandin, which cause the vessels to dilate. This can make it easier for the allergen to enter the body. It causes inflammation. Bronchoconstriction is the narrowing of the airway as a result of this. Furthermore, the inflammatory process causes vessel swelling, which results in the production of more phlegm. Mucus secretion is what this is. The pathogenesis and the pathology of asthma are also influenced by airway inflammation. Scientists determined a heterogeneous inflammation infiltrate with a mixture of eosinophils and neutrophils using activity film to study airway inflammation in acute asthma. In later asthma event, T cells activation is also a hallmark with elevated T cells markers in the blood and much more active CD8 cells in the tissues. Upon emergency hospitalizations, he has been diagnosed with various clinical manifestations of acute severe asthma, among which severe dyspnea is a vital one and need to be treated effectively. A person suffering from severe asthma faces problems in breathing and is often associated with several other distressing symptoms, such as not being able to speak complex sentences in one breath. This condition of breathlessness for shortness of breath is a respiratory difficulty experienced by the patient and is termed dyspnea. It is a complex clinical manifestation that is caused due to physiological impairment and can also possibly lead to trait of homeostasis. Emphasizing the major causes of this discomfort, dyspnea is primarily due to the result of a compromised respiratory system or a cardiovascular system. The pathophysiology of dyspnea is contributed to the failure of the pulmonary ventilation to match the breathing needs, leading to increased work of the respiratory system, tiredness, or air hunger. A misalignment of central respiratory motor activity with the afferent receptor of the lungs, airways, and the chest walls is responsible for dissociating pulmonary ventilation from the respiratory drive. Various physiological mechanisms, including acid sensing ion channel, mechanoreceptor, and the lung receptor located throughout the respiratory system, contributed to breathing difficulty. Information related to oxygen, carbon dioxide, and H+ levels in the blood is carried by chemoreceptors in the carotid bodies and the medulla. In those instances where they fail to respond appropriately, the dyspnea becomes more intense. Therefore, this explains the physiological conditions which lead to the clinical manifestations of dyspnea in an asthma patient as Jackson Smith. Corresponding to this situation and the identification of the pathophysiology of dyspnea, it is of prime concern as to what needs to be done and implemented to provide relief to Jackson Smith and improve his conditions. As Jackson Smith presents several emergency conditions of dyspnea, he needs to be provided oxygen and considered for heart mask. Dyspnea relief nursing interventions aims to reduce the afferent activity for respiratory muscles receptors, along with handling its effective component. Specifically, the intervention should focus on the techniques of gentle prolonged exhalation, as well as slow and deep breathing techniques, which are the post-sleep breathing, respiratory muscle training, body position exercise, and diaphragmatic breathing. In conclusion, I believe that I have been able to form a clear idea about the pathophysiology of several dyspnea and how breathing exercise can help to provide relief to the patient suffering from acute severe asthma. As my discussion of the nursing intervention, I would specifically implement breathing exercise to improve the condition of the patient under several dyspnea. Thank you for listening to my oral presentation.